Hi, I'm Dr. Brian Koffman, a retired family doctor and clinical professor. I'm also a CLL patient myself and the co-founder, executive vice president, and chief medical officer of the nonprofit CLL Society. Dr. Munir?
Hi, I'm Dr. Talha Munir. I'm a hematology consultant working at St. James's Hospital in Leeds, UK, and I lead the CLL group here at Leeds, as well as leading a few clinical trials in UK. And I'm really, it's my pleasure to be here with you, Brian.
Dr. Munir, you've done a lot of research with your colleagues in Leeds and beyond at looking at a concept that I think is important for patients to understand, which is MRD, or measurable residual disease. Before we get into the research that you recently published, I'd be interested if you could please explain to patients what is MRD, measurable residual disease, and why patients should know about this.
So I think in terms of explaining the concept of measurable residual disease, it's very important to remember that when we're looking at responses in treatment of CLL, we need to quantify how well the treatment has worked. And there are different ways how we measure the response, and some of that is simply measuring the lab markers, like looking at the normal lymphocyte counts and looking at the normal lab values for hemoglobin, red cells, white cells, and platelets. And also then we look at the responses in terms of the nodes and also the spleen and the liver size going back to normal. So that's what we call as the radiological measurements, and the other concept is the hematological measurements. And if all of that comes back as normal, we say to our patients that you've achieved a complete response. But
Well,
that's not the complete
remission,
story.
that
Yeah.
means you're in remission, right? Yeah.
Yeah. And that basically is the concept which has been used for a long time. When somebody has got a partial response or partial remission, it means that there is a 50% improvement from where we started from. Now, when we say somebody has got complete remission, there's different levels of complete remissions that we are talking about. We've got much more sensitive ways now to look into the disease, and one of the ways is this concept of measurable residual disease. So there is a blood test or a bone marrow test that we can do, and it can quantify the number of CLL cells that are still present in somebody's body. We know that when patients are in complete remission, there still might be about 10 million CLL cells still hanging about to virtually nothing at all. And we put them all the response into the same umbrella. With the measurable residual disease response, we can go down to picking up 1 in 100,000 cells, which could be a CLL cell, or sometimes going down to 1 in a million cells. Beyond that, the techniques we've got at this moment in time are not sensitive enough, or we need a lot more sample to be collected to go beyond the depth of that. And the measurable residual disease is a moving concept. You might be in a good response at 3 months, but at 6 months time point, that response might have deepened. And the measurable residual disease help us to give us the dynamics of the disease, how well the treatment is working for individual patient. So, in terms of how to explain, I explain it to the patients that, we have to look at this big hole where we all of our patients are captured into, and the measurable residual disease actually helps us to identify who is where in the paradigm of their treatment.
And a couple things that I wanted to follow up on that. The first is, I'm correct in saying you can be in a partial remission. Your nodes may have not completely shrunk back to normal, maybe scar tissue, maybe they haven't got back, but also have undetectable measurable residual disease. Is that not correct?
That is absolutely correct. And there is quite a lot of data to say that if somebody has achieved a partial remission and they have got no measurable residual disease left, actually the measurable residual disease response is more important than the partial response, because when we track the long-term outcome data, that follows more for the negative measurable residual disease response as compared to the partial response. So in a lot of the data for chemoimmunotherapy and some of the new targeted agents, it's becoming more and more important that achieving this goal might be a good place to start with, especially when we're using fixed duration therapy or the measurable residual disease guided therapy, which we hopefully we're going to talk about.
So let's switch to that and talk about some research that you just published that looked at what's called MRD-guided therapy and how that might be changing how CLL is treated. And maybe you can talk about that trial a little bit and what that means for patients now and what it might mean for them in the future.
So in treatment of CLL, there are two main concepts at the moment that we are following. One is what we call as continuous therapy, and that is primarily the bruton tyrosine kinase inhibitors like ibrutinib, acalabrutinib, or zanubrutinib to be given as long as it's working for patients. Now, none of the patients going on to these molecules achieve a measurable residual disease which is undetectable. So it's not a concept for that kind of therapy. But there is another group of therapies that we're using, which is called a fixed duration therapy, where we combine a drug like venetoclax with either a BTK inhibitor like ibrutinib or acalabrutinib, or you combine it with an antibody called obinutuzumab, or you can combine the three together. And essentially, in what we're finding is that the patients are achieving very deep responses and sometimes undetectable measurable residual disease, but not everybody is following that path. So some patients are achieving that level of remission, other patients are not. So the trial we did was looking at individual disease response for individual patients. So we had patients who were randomized to chemoimmunotherapy in the form of FCR. So these are the young patients who were able to tolerate the treatment. And then there were patients who were randomized to just receive ibrutinib on its own, and they just continued ibrutinib for as long as it is working for them. And the final group of patient was where we combined ibrutinib and venetoclax together. Now here where we found a lot of difference. So we looked at the measurable residual disease in every patient every 3 months. And what we found was that every patient was responding slightly differently. So the concept was that if somebody achieved a negative or an undetectable measurable residual disease at 12 months, we said that the same concept that there might still be a million cells which we are not able to pick up with our techniques, we're going to double the amount of therapy. So if somebody became what we call as MRD negative at 12 months, they will get 12 more months of therapy. A patient who achieved that level of remission at 18 months got 18 more months of therapy, so a total of 3 years. And somebody achieving that at 2 years will go up to 4 years, but the maximum we are going to give anybody this therapy is 6 years. And then all of the patients will stop at 6 years. So the duration of the therapy was guided by MRD, and the minimum amount of therapy that the patients could get was 2 years. The maximum was up to 6 years. But then there are a group of patients who were getting it for 3 years, 4 years, 5 years, and 6 years.
So what did you find with this and how does it inform how we're going to treat CLL now and in the future?
So it was a surprising result for us, and we published some of this data comparing this combination of ibrutinib venetoclax delivered in MRD-driven way to chemoimmunotherapy, the FCR, and we showed that this combination actually improves the progression-free survival, which means that the patients were not progressing. It was far superior to chemoimmunotherapy, as well as improving the overall survival for our patients, which was surprising on its own because actually in a frontline study showing an overall survival advantage is quite difficult. But even with the nearly we had a 4.5 year follow-up on at that time presented by Professor Peter Hillman at ASH in 2023, we showed this data. At EHA, what we found was that now our data has matured to 5 years. And
EHA is the European Hematology Association's annual meeting, and that was in this year, the 2025,
yes,
that you presented that. Yeah.
exactly, exactly. And in what we've shown this time round is not only MRD-driven I plus V was superior to FCR chemoimmunotherapy, but also to ibrutinib as well, both in terms of progression-free survival and again, surprisingly, overall survival as well. And I think that is what is game changing in terms of the trial outcome. And how I see it at this moment in time, that the difference in outcomes is primarily for this group of patients who have got unmutated IGHV. Now, we divide the CLL now broadly into two groups, the mutated IGHV and the unmutated IGHV group. And in simple terms, the unmutated patients tend to progress quickly and they tend to relapse quickly as well. When we looked at the data, the main beneficiaries of this kind of therapy were the unmutated IGHV patients. They were getting into deep remission quickly. Most patients, nearly 80% of the patients in the unmutated IGHV group, only needed 2 to 3 years of therapy, whereas the mutated patients actually were needing more therapy to get into remission. So the the main concept that the main benefit that we saw in terms of both progression-free survival and overall survival was for the unmutated IGHV patients. And it's my belief really at this moment in time where we stand with the data, um, we should use fixed duration therapy or continuous therapy for mutated patients and some unmutated patients, but the MRD driven therapy would be very beneficial for the unmutated IGHV patient given for 2 or 3 years. When you go beyond 3 years, the benefit is less and less pronounced. And that's not surprising because there might be some patients who might not be able to achieve that level of remission with this therapy. So that's what the next work we are doing on at the moment is looking at all the patients at who receive 2 or 3 years of therapy and how they are responding. And the good news is that the majority of the patients, nearly going up to 7 years of follow-up, are still showing very deep responses and are not showing any signs of progression. So I do think it's a concept that we're going to be utilizing more and more in future. But now our focus is to try to get approvals for this concept from the regulatory authorities.
Let me ask you the C word here, because I've heard it whispered about this. Could this be a potential curative therapy for some patients?
That's a very good question. And I think the answer would be when hopefully I can present some data in 3 to 4 years' time. And the concept really comes down from the MRD work that I've done along with Professor Hellman and Andy Rostron for many years. And what we found was that if patients are maintaining MRD negativity for a number of years, those patients are potentially cured. And if we say that in 4 or 5 years' time, when we have looked at all the MRD data for all our patients, if 30 to 40% of the patients are still MRD negative, I can safely say that some of those patients we would be able to say that they have potentially reached that point. But till then, I'll hold the cards close to my chest.
All right. Well, it's a very interesting concept, and I think that one patients need to understand this is happening more in academic centers and in clinical trials than in the community right now. Do you give us just in, briefly kind of what your sense of the future of MRD is? Is this going to get beyond an academic center or a clinical trial? Do you think that this is going to be something that's going to be helpful to patients going forward?
I think if you ask me an honest answer to that question, it's not there as yet at the moment because of the approvals and the regulatory authorities have legitimate questions about what method of MRD is being used, the techniques that we're using. But the concept is pretty clean. And we've used this in hematological cancers for a long time. We know that this tells you about the depth of remission. I think for a group of patients who essentially have got high risk disease, this concept is going to flourish. And I think we will be treating more high risk patients using this strategy. Whereas the low risk patients, we have got good treatments now for majority of the low risk patients who are going to benefit from fixed duration therapies and continuous therapies as well. But for the high-risk patient, there's really an unmet need for these patients, and this concept is now being utilized in a number of other clinical trials. So, like CLL18 is looking at the MRD-driven AM. Then there is some relapse refractory trials which are looking at this concept. So we will get some data on this in terms of the comparative studies in future. But if you ask me scientifically, if I want to treat a patient based on how they're responding to therapy, I think this is a much better way of defining the duration of therapy rather than just putting everybody, all the eggs in the same basket.
Dr. Munir, you and your colleagues at Leeds, I think, have been very innovative and had some really creative ideas. And I think this is another area where you're on the cutting edge of, I think, what's going to be important and what the trends are. Thank you so much for the research you're doing and the care you're taking of patients. Thank you.
It's my absolute pleasure. It's always a pleasure to talk to you, Ryan.
Always good to see you.
Thank you.
Good. All right. Thanks.
Thanks, Ryan.
Thank you. Thank you. I think that went well. Are we happy with it?
I'm happy with it.
Yeah. Good. All righty. I'll let you go because I know it's late on a Friday. But thank you so much for your time, and I look forward to seeing you in Krakow.
See you. Thank you.
All right.
Bye.
Have a great weekend. Bye now.
Thanks. Bye.